right, so we're just going to go through a case study now to sort of see the application of the protocols for the monitoring of blood sugars when folks are on no medications, oral medications with insulin, and with insulin. So we're just going to follow one individual through a period of time as she progresses through the various phases. So Miss A is a 31-year-old female to start with 3 children. She actually had normal glycemia in her first pregnancy, but after that pregnancy, she kept on an additional 10 pounds of weight compared to her pre-pregnancy weight. And so during the next 2 pregnancies, she actually was diagnosed with gestational diabetes. During those pregnancies, she was able to follow a meal pattern that was prescribed to her. She was instructed and was able to do some self-monitoring of blood glucose, and she actually did use insulin successfully to manage her gestational diabetes. However, with each pregnancy, she kept on an additional 10 pounds. So by the 3rd pregnancy, after she delivered, she was 30 pounds over where she had started prior to having any children at all. So when she comes in, shortly, about a year or so after her 3rd pregnancy, her weight, as you can see, was 175 pounds. BMI was calculated at 32, which puts her in an obese category. She was eating 3 meals a day, which was good, but she was not doing any exercise at all. This was post-pregnancy, again, not really diagnosed with diabetes at this time other than gestational diabetes, so she was not monitoring her blood sugars at this time. And her glycemic status on the visit revealed an A1C of 7.6%. So the patient was diagnosed at that time with diabetes. So you have a discussion with the patient, which really initially is centered around diet and exercise. And so if you look at the start phase of that, we know where she started. And so what we want to do is really encourage her to work on diet and exercise, and then just start checking her blood sugars so she can have an idea of where they are. And again, every time we check her blood sugar, it's going to be tied to an event. So in this case, for her start phase, we're going to instruct her to check her blood sugar daily before and after 2 meals. She did agree, and we would want her to try to do some carb counting. And so her meal plan could include something like 45 grams of carbohydrates at breakfast and lunch and 60 grams at dinner. And you may be encouraging her to use some measuring equipment to learn about portion size. And again, we give her a chart or a record where she can record her food intake and blood sugars. So at this point, newly diagnosed diabetic, we're really focusing on that diet and exercise, and any self-monitoring of the blood sugars that we're going to do are really tied to those events. And initially, in this case, really tied to understanding what her diet is and how that affects her blood sugars. So she comes in at 2 weeks. She's actually lost 4 pounds. Her BMI has gone down a little bit. She's able to present to us her food diary and her blood sugars that are associated with the meals. And we talk a little bit more about carb counting. So we focused the first 2 weeks on the diet, and now we're going to encourage her to start to exercise. So we talk about what kind of exercise regimen might work for her, what would be, and again, it's useful at this point to find out what is available to her and what kind of exercise that she's interested in. In this case, Miss A was agreeable to add a 15-minute walk to schedule each day. She's agreed to continue with the carbohydrate counting, the self-monitoring of blood sugars, and the record keeping, and we'll add exercise. And again, for this time, while we're looking at things, she will still be testing her blood sugar pre and post an event at least twice a week. And so again, whether that is a dietary event or an exercise event, she will be testing pre and post. She was very pleased at this time that, that she would not have to be started on oral medications or insulin. Again, you really want to congratulate her on her 4-pound weight loss at this time, as well as her commitment to doing that carb counting and really sort of starting to understand what will affect her blood sugars. So we send her off to start her walking program and probably have her come back in about 1 month. So at that time, she's now come back. This is her third clinic visit after her new diagnosis of diabetes. We're 6 weeks in. We've really focused to this point on diet and exercise in a sequential manner, tying whatever blood sugar monitoring that we're doing, not overly so, but to the events, and only doing it two events per week. So at this point, she's lost another 4 pounds, down to 163 or 167, and she really has been doing well. At this point, she's been 6 weeks out. It would be reasonable to check another A1C on her, and we did so in this patient, and her A1C is down to 6.5%. So she has really made good progress in understanding sort of what will impact her blood sugars, how she can affect them, how diet will affect her A1C, as well as changing her diet, and exercise will affect it. So at this point, we say, well, you're doing really well. You've been very successful in what you've tried to do. We would, at this point, say we want her to continue to do carb counting. It's a good idea to continue the food diary, continue the walking and try to increase that walking or whatever exercise program that she does. And at this point, she's very well controlled. You could tell her to really test once a week and then maybe tie it to an event. So really 2 tests per week, but they're tied to a particular event. And at this point, you say, let's come back in 3 months and see where we're going. So time goes on. You continue to see her every 3 months over the years, and her blood sugar stays stable, but she now has 3 kids, and life is getting away from her. And after a couple years, you know, it's starting to develop where, you know, she's not being able to control things perhaps so well with the diet and exercise. Her A1C 4 or 5 years later has crept up from the 6.7% after the initial intervention to 7.8%. She has continued for the most part to do what she can with the carb counting and the exercise, and after discussion with her, she really says, you know, I don't know that there's much else I can do with my diet and or exercise. So at this point, with a goal A1C in this patient of 7%, she's at 7.8%. You talk about oral medications, and you start her on Metformin. You instruct her on signs of hypoglycemia, which of course you wouldn't expect to see with Metformin, but always a good thing to cover. And basically, we now review with her the protocol for self-management of blood glucose when oral medications are used. So this is her first visit back at the 4 to 5 years. Again, her weight has crept up from that low of 167 to 180 pounds. She does still eat 3 meals a day. She's doing the carb counting. She was able to increase the duration of her walking. However, she's only walking 3 days a week. And she had continued to test on a weekly basis. But as we said, her A1C had crept up to 7.8%. So we're starting her on Metformin. We talked to her again about the carb counting and the use of the food diary and tying the monitoring that she's going to do with meals. We encourage her to continue walking, and if she can walk more than 3 days a week, that would be great. And we say, well, after we started you on the Metformin, what we really want you to do is for the next 2 weeks, we want you to check your blood sugar 2 to 4 times daily, and we want it to do before and after events. So really what we're asking her to do is to check it, to monitor 1 to 2 events daily pre and post, and to do that for 2 weeks after starting on the Metformin. So she comes back in 2 weeks. She's lost 4 pounds. She, again, continues the 3 meals a day, does the carb counting. She's not been able to increase her walking, but she says that her blood sugars fasting are now between 120 to 150, and her 2-hour postprandials are less than 200. So then we say, well, let's think about this. Let's go ahead and increase the metformin to maximize that. So probably if you started at something on either 500 milligrams at nighttime or 500 milligrams BID, you can increase that appropriately to what she would tolerate based on her symptoms. And then you say, well, okay, so we still want you, you've tolerated the metformin, we're going to increase it, we don't really expect you to be hypoglycemic, but let's just reduce our monitoring now to 2 to 3 days a week for the next 1 to 3 months. And again, we always want to tie it to into an event. So now you see her back at 6 weeks. She's lost an additional 6 pounds. And her A1C has reduced from 7.8% down to 7%. And so she's doing a good job. She's at goal. She's probably at this point on metformin 1,000 twice a day. And really what we say is, well, we're just going to maintain you. So really what we want you to do is continue the carb counting, continue the food diary, continue to try to increase that exercise. And again, just like the maintenance phase with the diet and exercise, you know, she's well controlled. Test before and after an event, but otherwise you're doing really good. At this point, you probably also do just want to review with her, again, the events of the meal or the snack or the exercise or hypoglycemia, and talk about when we would see her again. So she does really well again on the metformin twice a day, kind of hanging in there, doing what she does. And by now she's got the 3 kids and they're all teenagers and she's running around a lot and being really, really busy. And so she comes back 5 years later and her A1C has continued to creep up. So she presents to you and her A1C is at 9.5%. You've maxed her out on the metformin, and you talk about whether you really want to start a sulfonylurea or whether you really want to go to keeping her on the metformin or really starting a bedtime insulin. And honestly, you know, starting that bedtime insulin is probably the best choice in this patient. Her weight's crept up. She's at 183, and so what we say is, well, what we're going to do is we're going to start you at 5 to 10 units of NPH at bedtime, and that really what we want you to do is check your fasting daily for a week and return to the clinic for adjustment at that point. Again, reviewing with her the signs and symptoms of hypoglycemia and how to treat that. So she comes back in at that 1-week visit. She's actually gained 2 pounds. So one of the things when you start insulin that you do need to warn folks about is that they will most likely gain weight. Very, very frustrating for patients. But it's something to address up front and just encourage them to increase their exercise, watch their diet, but unfortunately, frequently people will gain weight once they've started insulin. Again, talking about diet, talking about exercise, you know, her fastings are back down to 120 to 150 where they were when we first started metformin, and her 2-hour postprandials are all below 200. So overall, she's doing pretty well. So depending upon what dose of insulin you started, you could adjust it a little bit if you want a little bit of tighter control, you know, by increasing a few units. And now we kind of want to see not only what her fastings are doing, but also let's try to look at events. So the question that you're really trying to answer at this point is bedtime insulin enough, or do you need to look at multi-daily dosing of insulin or changing the insulin regimen? So she comes back at 4 weeks. She's gained a little bit more weight, but her A1C at this point has decreased from the 9.5% to the 8%. So she's a little bit frustrated, but she's happy that her blood sugars are improving. And so what we say is, you know what, we're going to hold you for now, potentially, and sort of see where it falls out. Continue to work on the diet and exercise. At this point, I would probably bring her back in another 3 months, hoping that she creeps down closer to 7. And at this point, we know that she's not being hypoglycemic, so you could probably get away with just testing the fastings once a week and then pairing some blood sugar tests around an event once a week. So again, just sort of the where we're going to go for the start, adjust, and maintenance phase for oral meds and bedtime insulin. So then what happens is she comes back at that month, and she really check her in that 4 to 6 weeks, and she's really hanging around 8%. Maybe she's crept up to 8.5%. And so at that point, you really need to talk about we need to add an additional insulin. And so once you get past bedtime insulin, there's many different ways to do insulin, whether you're just doing twice-a-day insulin on basal insulin, whether you're doing multi-daily dosing, or whether you're using long-acting analogs. But once you start past that nighttime dose of insulin, you really are talking now about a whole different protocol for how you're going to monitor your blood sugars. And so specifically, more than likely, you are going to be doing corrective dosing if you're doing multi-daily dosing. And so then you're going to be requiring patients to test their blood sugar pre-meal and post-meal. So potentially, depending upon how the insulin regimen goes, past just the bedtime insulin, I mean, you could be having folks check their blood sugars anywhere from really 2 to 6 times per day. So that's a whole other discussion that hopefully that we'll be able to have on another call. But hopefully what we've done is sort of walk you through, how blood sugar monitoring should be doing as the patient may progress through that diet and exercise phase, to that oral medication phase alone, and then maybe to the oral medication phase with bedtime insulin. One of the things that, and I just throw this up there because as you have that discussion with people about events, just to remind people, that a snack is not a meal. A snack is really considered to be that 100 calories or less. And so you really want to think about, what you're taking in, how many calories, again, going back to that initial discussion, really to folks about measuring what they're eating, portion sizes, and understanding what meals are and what snacks are. Certainly as we go into further discussion on insulin and snacks potentially involving it is a more complex discussion. Again, just a reminder when we talk about exercise, blood sugars can do wonky things when people start to exercise. They actually may see their blood sugars increase initially, and then they may see them decrease. But that's one of the reasons why, again, we consider it an event and we consider it something that we want to test pre and post so we can understand how that event actually impacts what our blood sugars are. Always have the conversation about how to recognize the signs and symptoms of hypoglycemia and then how to treat it, right? So if your blood sugar is low, and various people will feel that low blood sugar at various levels. Many of us have had patients who are convinced they feel hypoglycemic at a blood sugar of 110. And other people can go down to 50 and not feel anything. But the key is just do make sure that you talk about how to treat it and that it doesn't require eating an entire box of candy to treat it, right? Or an entire jug of juice. That really, in order to treat hypoglycemia, you're talking 4 ounces of juice or 8 ounces of milk or, a couple graham crackers, but we're not talking about necessarily needing huge amounts. And then again, once they've started that bedtime insulin dose, they should have easy access to their meter. If they wake up in the middle of the night and they're feeling shaky or hungry or just feeling weird, they should be encouraged to go ahead and check it, just so they can make sure that they're understanding what's happening to their body and they can take the appropriate steps. So hopefully that has sort of walked you through the protocols for self-management of blood glucose on diet and exercise, oral medications and oral medications with bedtime insulin, focusing on start phases, adjust phases, and maintenance phases for all three of